All right. So now I'm going to introduce our next three speakers and play their pre-recorded presentations. So this is going to be entering a session on reimbursement, and then we will get to some other regulatory things at the end. So Tom Scully is a general partner with Welsh, Carson, Anderson, and Stowe, the most active U.S. private equity investor in healthcare. In addition to his portfolio companies, Mr. Scully also serves on the board of directors of the Health Management Academy, who provide research, knowledge sharing, and leadership development to leading U.S. health systems. But before entering private equity, he was the administrator of the Centers for Medicare and Medicaid Services and the president and CEO of the Federation of American Hospitals. And he had an instrumental role in designing and passing Medicare Part D and Medicare Advantage legislation, and initiated the first public reporting and disclosure for comparative quality among hospitals and other healthcare providers. And he'll deliver a special lecture on reimbursement through the eyes of CMS. Dr. Jill Hagenkord is the Chief Medical Officer of Optum Genomics. She's a board-certified pathologist with subspecialty boards in molecular genetic pathology and an additional fellowship in pathology and oncology informatics. She specializes in the development, validation, and implementation of novel health technologies, as well as coding, coverage, and reimbursement issues for novel tests. Prior to joining Optum, she was the chief medical officer of several Silicon Valley genomic companies, including 23andMe, and she will deliver a special lecture outlining reimbursement criteria from a private insurer's perspective and discuss how UnitedHealth Group uses evidence and economics to make clinical reimbursement decisions. And then you'll hear from Dr. Mike Broad, who is Data Strategy Director at the Focused Ultrasound Foundation, and he will present the basics of procedural reimbursement and its impacts on specific stakeholders, explore the landscape of global focused ultrasound coverage, and highlight the Foundation's efforts in this area. So enjoy the presentations.
Hi, my name is Tom Scully. I'm proud to be a member of the council and consider Neil to be a good friend. I've gotten to know him over the years and very happy to be as supportive as possible. The reason he asked me to talk about CMS this morning is once upon a time, many years ago, I was the CMS administrator. So I was actually the HICF administrator in 2001 for George H.W. Bush, and then I changed the name to CMS right after I got there. I was there for about 3.5 years running CMS back then, and for the last 19 years, I left in 2004, last 18 years, I've been a partner at Welsh, Carson, a New York private equity firm, and we're probably the most active U.S. healthcare investor. So happy to talk to you about this morning. Other backgrounds: before that, I ran a hospital association, the Federation of American Hospitals, which is HCA and Tenet and all the for-profits. I was the CEO of that during the 90s, and I was President Bush Senior's healthcare advisor in the White House, an OMB for 4 years during the first Bush administration, 89 to 93, and worked in the Senate for many years for that. So I'm old, and I've been dealing with CMS for a long time. So Neil asked me to give you a little background about CMS and how they think about focused ultrasound. And the bottom line is they don't think about focused ultrasound. It's a wonderful agency. I still spend some time up there. I'm very friendly with just about everyone that's had that job, including the current administrator, Chiquita, who's wonderful. It's a giant place, has 6,000 employees that work there full-time in Baltimore and 10 regional offices. About 50,000 contract employees, which I'll get into, who are called Medicare administrative contractors. There's 12 of them around the country that basically run Medicare, largely working for Blue Cross plans. In fact, over the years, quietly, Blue Cross of Florida has bought up the bulk of them. So there's 12 of them that basically contract for CMS to run Medicare around the country, and they make a lot of decisions that affect this. So does CMS sit around and think about focused ultrasound or any new treatment? No, they don't really. You have to bring it to them. So you can get approved from FDA as long as you like. And FDA can approve a new device or a new treatment, but that doesn't mean CMS is going to pay for it. And the system, I think, is very fair, but it's very complicated. It's essentially set up on the premise that you've got to show them why you need to get paid more than some existing treatment out there. And it's quite a high bar for a variety of reasons, mainly that over the years, everybody wants more coverage for everything in CMS and Medicare, and the program is growing like a weed and is very expensive. And so generally there's a feeling that we don't want to cover new things because everybody wants to get paid for more all the time. And there's never a shortage of physicians or other practitioners or hospitals or outpatient centers. Nobody's asking to come in and get paid less or for fewer things. So it's a bit of a high bar, as it probably should be. It's not simple, and it's a complicated place. So CMS process is generally, in your case, I think it'll be covered mostly by the 12 max Medicare administrative contractors. So each one of those is generally a Blue Cross plan. As I said, most of them are quietly subsidiaries of Blue Cross of Florida, about over half. But those 12 regional Medicare administrative contractors make lots of coverage decisions. So they may decide on their own in the Southeast or the West or the Northeast, wherever the region is, to cover a new focused ultrasound treatment under existing code and allow Medicare to pay for it. That doesn't mean commercial payers are going to cover it. Doesn't even mean that Medicare Advantage, private Medicare plans, which is now almost 50% of the Medicare program, program I had a lot to do with designing, are going to pay for it. It's only Medicare. But generally, since most of these docs that make the coverage decisions for local Medicare administrative contractors are working for a Blue Cross plan, and someone after me is going to talk about this United, generally the private insurers tend to cover Medicare. It's hard for them to say no if Medicare covers it. And it basically gives them an excuse and a reason they cover it if Medicare does. So frequently the Medicare decisions are the leading edge for everything else. So generally, when you come with a new treatment like focused ultrasound, you may go to FDA and get it approved. And that means absolutely nothing for getting paid. It just means that it's safe and effective to be used in the United States. It has nothing to do with payment, which a lot of people don't understand. Then they get mad at CMS for not paying for it. Well, CMS has a very complicated process to pay for it. So your first track generally is to go to a regional Medicare administrative contractor and say, look, this focused ultrasound is wonderful for treating a new tumor that hasn't been covered before. And they can on their own decide to cover it, but it's generally covered within an existing payment code. So as most of you probably know, I know the focused ultrasound can be covered in inpatient or outpatient, or in some cases a physician's office. There's three totally different pots of money and three totally different processes, whether you're trying to get paid for it as part of an inpatient hospital procedure, as part of an outpatient hospital procedure, or in a physician's in a clinic, outside of either one. And they're all totally different. They generally overlap a little bit in the coverage decision, but the pots of money are totally, completely separate. So if you go to a hospital, try to use focused ultrasound, let's say in a cancer patient, generally, you're going to have to get that treatment approved as safe and efficacious by the FDA and as being okay to provide as part of a payment for CMS, but it's going to generally be covered under an existing cancer code. So let's say it's uterine cancer. They're not going to pay you a separate amount. They're going to say, okay, that's an acceptable treatment under your bulk DRG or diagnostic related group of Medicare to pay for as part of a uterine cancer if you're at Cleveland Clinic, and that's going to be acceptable. They're not going to pay you more. You can go back for treatment and apply for a temporary add-on code for 3 years if you can convince CMS, which is a national coverage decision, that this treatment is so important on top of other cancer treatments that they should carve out a separate payment code for 3 years, which they can do on the hospital side and track it. Doesn't happen very often. It's very high bar again. And they cover it for 3 years, and at the end of 3 years, if they think the data is good enough, they will add on a new DRG that will say, for example, uterine cancer with MRI plus focused ultrasound. So you can get an additional payment. That's the only way to get it done on the hospital side. And no matter what you do, you're going to get paid as part of the hospital DRG. On the outpatient side, there's a separate payment system for outpatient, very similar process. You have to get approved for the specific treatment to be part of an existing code. You can get what's called the pass-through code for 3 years. Well, CMS will pay more. Just to give you an example again, let's say it's an MRI with a focused ultrasound add-on. They will pay for that if you make the argument and convince them this is an absolutely unique and underpaid diagnosis. They can give you a code and pay you for 3 years. Again, very difficult. Entire staff that looks at this at CMS. And they will give you a new code for 3 years. And if they agree at the end of the 3 years that this is unique and you need to pay more, they will carve out an additional code for you on the outpatient side. Not easy to do. You have to show it's a substantial improvement in treatment, that it's new, that it's not covered, and shouldn't be covered under the bundle. So as you can tell, and I'm sure you're all aware, CMS is really moving heavily towards bundled payments. So whether you're in the hospital side and the inpatient side, or they're on the outpatient side, they're trying to pay people a bundle. They don't want to get into paying for specific sub-treatments. They want to give you an oncology bundle for uterine cancer or breast cancer, whatever. So here's the overall payment bundle. Call me in 6 months. They're a long way from getting there. A lot of stuff is still fee for service, but that's where they're going. And that's why they're hesitant to do no carve out codes. The third way you get paid is in a physician's office. So you probably know, comes down to a thing called the RUC, which is essentially crazy operation where they basically have a council like a UN of docs, which was created again while I was involved. Never should have let it happen. It's basically a subset of the AMA. You have to go to the RUC and argue to them that you need a new code. And it's essentially a budget neutral pot. So if you're out there looking at the couple $100 billion that we spend on physician payments every year, and you want to add on a new physician payment and a new facility fee, both, by the way, are covered in this, under Medicare Part B, you have to argue to create a new code. And there's 66,000 some codes, and they all have to be in roughly a zero-sum game, from everything from brain surgery to a primary care visit. I'm sure you're all familiar with this. You need to get an RVU and a code that pays for this. And to do that, you have to show that you're a new and wonderful treatment that deserves a code. But if they add this into the pot, they're carving it out of somebody else. So there's a lot of hesitation for the physician community, where you can imagine you're sitting around a table with gastroenterologists and urologists and surgeons, and that's the way the RUC works. They make a recommendation to CMS. CMS doesn't have to take it, but they don't have enough staff to do it otherwise. They usually do. You have to argue that focused ultrasound needs an add-on payment and a new code to be paid for. And to do that, you're going to carve it out of somebody else's hide. So you can imagine that is not easy either. So the bottom line is it's a very complicated process. I think it's a fair process. The CMS staff, of those 6,000, probably over 6,000 people that work at CMS now, probably 10 of them are political. Most of them are in Baltimore. This headquarters in Baltimore and 10 regional offices, but the major decision makers are in Baltimore. It's very apolitical. I think they're generally great people. I think they're very fair. They're also very hesitant to add new payments and change. So it's a high bar to go in there and get them to pay for things, as it probably should be. But it's really complicated. So you come in and say, look, we have a wonderful new technology, focused ultrasound, driven by an MRI, and why aren't you guys paying for it? You have to go in and show them why they should pay for it. You got to show them why taxpayers should pay for it. As a general matter, most insurance companies won't pay for it unless you go in there to begin with. So when you think about how does, as Neil said, well, how do you think CMS thinks about focused ultrasound? There is probably nobody at CMS thinking about focused ultrasound at all. There may be, a couple of the regional 12 medical directors who may be friends of some of yours or have a close relationship, or somebody at, Baylor Scott and White or Cleveland Clinic or Harvard has gone in and argued this payment should be there. But it's a grind, and you really have to focus on it, and you really have to get in if you want a separate payment. Otherwise, and it may be fine, you're going to get paid under the existing DRGs and the existing, which are the inpatient hospital codes, and the existing APCs for outpatient payments. And you're going to have to get paid in the physician's office and for under a cancer code that already exists. If you want to get an add-on, it's a lot of work. And I think CMS is fair, and they do a lot of, they make a lot of changes for new technologies, but it's not simple. It's not easy. And nobody should expect people to show up at CMS and say, wow, we just read this paper that you guys printed and we're going to pay you more. It just doesn't happen that way. So it actually is a wonderful agency. I've been out there for 20 years. I don't spend much time there anymore, but I can tell you that I think the career people are really nice and really fair. They have a lot of really good career docs, not enough. But they will listen and they will look at evidence, but you got to have a really focused campaign and a really long outlook on how to get this done. And you're swimming upstream a little bit to get new payment codes, because as I said, their overall trend under Democrats and Republicans, no matter what, the last 15 years has been bundles and bundles and bigger bundles. They're trying to go against more carve-outs and more special payments. And if you're going to treat uterine cancer or breast cancer or bone metastases, whatever it is, and a lot of things I've seen you have covered or trying to get covered, they're not looking for rifle shots. They're looking to put people into more and more bundles and find a way to get you all to treat patients with lots of different technology and treatments the way you see best under an overall capitated amount. So on the other hand, they do like new technologies, and they really think something is significant or dynamic. They will add a new payment, and they will track it, and they will work on it. But it's a bit of a hustle and a bit of a grind. So I would say overall, I'm sure the folks from United are going to talk about this later. It's a really complicated process. It's not easy. No one's going to show up and pay you unless you're really working hard. I've talked to Neil about that. But it's fair. And I think CMS is basically, from a taxpayer point of view, they do a very good job. They tend to be maybe slower than you'd like, but they look at it as protecting the Medicare trust funds and making sure that they're using the funds rationally for beneficiaries as they should. And since I'm going to turn 65 in a couple of weeks, I think that's a hell of a good idea. So anyway, I hope that this is helpful. Neil asked me to give you a little outline. Anybody wants to call me and talk about it, or anybody wants to get more counsel about how to deal with Medicare administrative contractor medical directors who you'd probably be chasing around, or there is a coverage staff at CMS. You can go in and get a national coverage decision and have them, as I said, do a 3-year pilot add-on and give you a different code for payments. It's hard, but I'm happy to give you advice about how to do it or talk to you about it. But I think, as usual, most people in the government are trying to do the right thing. They're usually pretty slow and pretty methodical about it, and that's going to be the case with coverage for your payments. But I think you're at the very beginning of a process where you're very likely to get a lot more attention, a lot more coverage. So Neil has totally convinced me this is the greatest thing in treatment. And so I hope I can help him, and hopefully I can be supportive, and look forward to working with all of you. And thank you for including me in your conference.
Hello, and thank you for the opportunity to speak at this conference. My name is Jill Hagenkord. I am the Chief Medical Officer of Optum Genomics. I'm a board-certified pathologist with subspecialty boards in molecular genetic pathology and an additional fellowship in pathology oncology informatics. That's a really long way of saying that my expertise is in the design, validation, and implementation of clinical lab tests or in vitro diagnostic devices. And I recognize that the device that we're talking about today is more of a traditional medical device, but a lot of what I'm talking about how do you develop the evidence and the evidence narrative to ensure the quickest possible route to widespread adoption and coverage of your device. It applies to in vitro diagnostics, to traditional medical devices, to medical apps, to software as a medical device. So that it's kind of the same cadence and the same recipe works for all of these types of products. We've got the added complexity in clinical lab space or precision medicine space, where there's kind of a regulatory loophole for these tests. They're called laboratory developed tests, and they actually don't have to go through the FDA prior to going on the market. And so we've kind of got some additional degrees of freedom and Wild West, which makes this evidence development and narrative process even more of an imperative. And regardless of what kind of device you are, it is estimated that it takes 14 to 17 years to get a health product from product concept to widespread coverage and adoption. And I mean, there's two reasons for this, basically. One is that you do have to have a lot of evidence that this device is safe, that it works reliably and reproducibly, and that it provides some kind of beneficial outcome. And depending on your intended use, that can take a very long time to build that body of evidence. However, it's been my experience that this time to widespread adoption is lengthened because oftentimes the test developers are coming from a space where they're not familiar with the market access complexities of getting a health product adopted. But usually research scientists or physicians who have really just focused on their practice or academic practice rather than somebody who's been in industry. And having been that kind of physician before, I know that I didn't know this stuff. They don't teach it to you in med school. But there is an entire strategy around how you develop your evidence, what kind of evidence you need, why do you need that evidence, and how do you tell that story? And so that's kind of more of what we're going to talk about in these next 10 minutes or so. And hopefully, that these are the kind of strategies that can move this 14 to 17 years into something that's more like, hopefully 5 to 10 years, depending, again, on your intended use. This slide is, what I work on every day, which is the in vitro diagnostic medical device type. And I've got this kind of set up in a vertical stack. The next slide is going to be just the generic medical device, and it's going to be on an x-axis, but it's kind of all of the same information. And it's kind of the same basic evidence content that you would need to make a compelling story to a stakeholder like a professional society group or health plan payer, medical director. So first of all, And this is a step that gets skipped more often than one might think. What is the test's intended use? And it's common, I think, for people to approach a health products with a technology, whatever it was that they worked on in grad school or postdoc, or some kind of technology that they're very excited about, and then come in and look for a problem. And usually the more successful route is that if you actually identify a problem, characterize that problem, and then come up with a solution that is best fit to solve that problem, rather than letting the technology lead. In this case, I understand, right? The technology is kind of already baked and mature, and now it's a matter of, what are the different applications? What are the different intended uses? And what is the evidence that we need to get there? And I believe in many ways, I know that there have been some FDA authorizations for this technology. So this kind of concept of analytical validity, does my test work, has been established, at least, for certain intended uses. Biomarker is, I don't think, applicable to this particular device. This is the clinical validity step. It would only be applicable if you're trying to predict something, predict an adverse event, predict response to a drug, predict a likelihood to get a disease. And that's a measurement of the predictive ability. In the precision medicine space, this evidence step is the one that is most often skipped, and people try to go straight to the clinical utility. And they spend a lot of money and a lot of time doing a clinical utility trial based on faulty information, and didn't design their clinical trial properly to pick up their signal, because they overestimated the predictive ability of their biomarker. And I think that's just informative of how people can kind of waste time and money and resources in this process, evidence development process, by thinking that you could take a shortcut. But I've been doing this for 25 years. I've never seen a health product succeed that tries to take an evidence shortcut. You might get some short-term win, but eventually it catches up to you, and it'll fall apart. And you may have hurt a lot of people inadvertently in that time period by trying to skip the steps. But clinical utility very much applies to focused ultrasound and the specific intended uses. And this is determined, unlike the validity, like does the instrument work, is kind of in the purview of the FDA. The clinical utility is determined by the payers and the individual physicians and professional societies. And this is where it can get a little tricky, right? The validity studies are kind of a recipe. And there's not a lot of room for interpretation. Like, this is how you have to set up the study, and these are the outputs that you have to have. You don't get to well, what if I want a different output? It just is what it is. Clinical utility, what you need to measure and what is the right study design is going to be different depending on the test's intended use. So there is no one size fits all answer. But this is where you want to be able to get feedback early and often from clinical champions. Who can help you get information around, what are the right endpoints. Then do your study design, and then take that in front of the stakeholders, right? Then go get feedback from the payers early and often. Are these the right outcomes? Are these the kind of outcomes that would impact your decision making? Are we missing an outcome that you would need to see? Is the timeline for our data collection points the right interval of timelines? So and there are ways, and there's consulting groups, and like my group helps with these in vitro diagnostic tests, actually get that payer and provider feedback. And in doing so, you can actually shorten your time to that coverage determination, and not be surprised on the other end of your clinical trial that it wasn't appropriately powered, or that it didn't answer a key question that the stakeholders would need to see. This is that same graph, but now it's laid out horizontally on the x-axis and applied to the medical development process in general. And I really like this paper, and it's a paper about how medical experts need to be engaging more in the early device development process. The one thing that I do have that I would change a little bit about this graph is, so it's showing the preclinical phases of proving that the instrument works for what you want it to do and that it's reliable and reproducible. And then these are your phase 1, 2, and 3 clinical trials as needed. And it has market access starting here at the end of phase 3. And I would actually argue that if you want this to go fast and as fast as possible, you need to start doing some people call it early market access or market development work, really all the way back, as soon as your basic research looks like this is something that might work. You want to be engaging technical key opinion leaders, even as you're still working out the technical capability of this device, and have them participate in your validation studies, and then get them on a technical podium telling that story about the reliability and reproducibility of this technology. And you want to be thinking early on, before you get to these clinical trials, who are my clinical champions? Who are the clinical key opinion leaders that I'm going to want to work with? And be planning, 2-3 years ahead, because you want to make sure that when your evidence drops, that you're ready and hot off the press to go onto the right podium with the right key opinion leader to tell that story. You also want to start thinking about a lot of other market access needs very early in your process as well. So this is why yes, you need to have the evidence and understand why you need the evidence, but you also need to have a go-to-market strategy as well. And that includes things like, when you're at the very beginning of the process, right? Is this a good product market fit? Is there a clinical need? Validating that there's a clinical need. And then, quantitating, what is the opportunity here? Like, what is my total addressable market? What are the competing technologies or devices that are being used at that point in care? And how much of that market do I think that this test can win? These are all things that you need to model out as, to even make sure that this is a viable thing that you should be investing your time in. You got to make sure that there's a place that it's going to fit into the healthcare system at the end. And again, this concept of the key opinion leaders, thinking ahead about what podiums you want to be on. Coding, coverage, and reimbursement. Start thinking about that as early as you can. And I wish I could give you a one-size-fits-all strategy for how to do this, but it really is, you have to work with somebody who's got experience in your device type to understand all the nuances of which kind of CPT code you want, which fee schedule are you going to get it placed on, and the downstream implications of that. And so and then of course, who's going to cover it? And unfortunately, this can vary widely. It isn't systematic. Once you've talked to one payer, you've talked to one payer. So you really have to have a team of people out there with a nice, crisp evidence dossier, with a nice frying pan to the face narrative to go with that evidence dossier, taking it to these payers and key opinion leaders. And early and often, like, you don't have to have the evidence fully developed in order to engage a payer and be like, hey, I know I'm only, just getting started on my clinical trial. Wanted to give you an update on what we're doing. This is when we anticipate it being done, and just kind of, be there and reminding them about your product and how responsible you're being about your product and the evidence generation around it. Medicare works by MACs, which are Medicare Administrative Carriers. And I should know this number, I'm going to say 12, 15 MACs in the country. So they cover big regions of the United States. But each one has their own coverage determination process. And it is possible to get an NCD, a national coverage determination. It doesn't happen that often. It is possible, but that would actually cover all of the MACs at once. But usually what you have to do is go to each one of these MACs and submit your evidence and obtain a coverage determination that way. There are also evidence review entities like Hayes and ECRI and Evidence Street who do evidence reviews as well. And the payers use those, some more than others. A lot of payers, private payers, will actually, they'll only do peer-reviewed literature and maybe only use Hayes and ECRI to, kind of validate their reviews, but not as their primary source. Then the private payers usually will negotiate their rates based on some factor of the Medicare fee schedule. So that Medicare pricing determination that you get does have implications when you're also trying to go into the commercial market. So it's important to get that right. Medicaid, I have to be honest, in my 25 years, although we all talk about we want to do Medicaid, like it is so complicated. Each state has its own unique Medicare system and Medicare laws. And so it really does take a lot of resources to kind of champion in a new technology to get Medicaid coverage. Really has to be done almost by lobbying on each Capitol Hill, for each intended use of your technology. And then, everybody wants to avoid any kind of friction in the ordering process, and so prior authorizations are often a concern. These things can be more automated and reviewed if your CPT code can clearly be matched up to a ICD-10 code, right? So I can clearly tell what test is being done, and it's got eligibility criteria in the policy, and I can tell by the ICD-10 alone what should be covered. That can be automated, and in those cases, you're less likely for prior authorizations unless there's concern about misordering of the test or fraudulent coding, where they're trying to kind of catch that up front as well. So those are the kinds of things that can trigger a prior authorization, and anybody who's helping you develop a coding coverage and reimbursement strategy will be, kind of keenly aware of everybody's desire to avoid that trigger. But it is definitely something that you need to think about as you're developing your go-to-market strategy. So this is my last slide. In summary, this kind of combines everything that I was just saying together on this. It's not just an evidence journey, and it's not just enough to have evidence. You have to be able to tell that story well and articulately and support each claim with evidence. You have to make sure you're solving a real problem in medicine, and that care gap is, significant, and that your device can actually impact that change in care and insert yourself into that marketplace. There's also the ability to, at the end of the journey, after you've already got coverage and adoption, you can, try to watch the behavior of your device in the wild and identify any implementation blockers, and, put resources towards unblocking those implementation gaps. And so those are all the types of things that you need to consider when you are bringing a medical device from product concept through widespread adoption and coverage. Thanks very much for your time.
For the next 10 minutes, I'd like to describe to you the current status of global reimbursement for focused ultrasound-based procedures. So the agenda today, first we'll talk about the basics of reimbursement, why reimbursement matters, the coverage landscape, and foundation efforts in this area. First, the basics of reimbursement. This is clearly not just the basics of reimbursement. In fact, this is the sum total of all pathways for reimbursement. The important things to remember is that for reimbursement, you need regulatory approval, a billing code, payment levels, and coverage. I'd like to describe a couple of these in more detail. A coverage is when an insurer, or either government or private, has agreed to pay for the procedure. The payment rate is the amount the treatment site and treating physician will be reimbursed if the procedure is covered. So why does reimbursement matter? Without sufficiently broad coverage, patients must pay out of pocket and or travel long distances to get their treatments, which is cost prohibitive for most of them. Without a sufficient payment rate, the procedural cost to a facility of performing the procedure is outweighed by the payment rate, and as a result, facilities can, and in the past have, refused service. And without proven success in coverage and payment rates, the innovation of new devices or modalities is stifled. The reason this matters to the foundation is that under all of these conditions, patients are effectively denied access to existing or novel FUS-based procedures. This is the global coverage landscape. Along the top are the indications, along the side are the different regions and countries in those regions. Note that the black dots mean that there's full coverage in the country. Regional coverage, as in the case for Italy, Canada, and the United States, indicates regional coverage, and the white or open dots are codes that are not specific to focused ultrasound, but can be used to build focused ultrasound-based procedures. I'd like to now take a look at this on a map. You can see that the number of indications varies greatly between countries. For example, you have Germany with 7, China and Finland with 1, Canada with 2, and the United States with 5. This is all a reflection of that table I just showed you. I think what's more interesting is if you look at those indications that are approved but not covered, paints a very different picture. And to me, this suggests that there's great potential for more covered indications in the future. I'd mentioned the partial coverage or regional coverage. If we look at the US and Canada, you can see that there are some states where all 5 indications are covered. There are others where 4 are covered, others where 3 are covered. And in Canada, Ontario is the only province that has coverage, and that is for essential tremor and uterine fibroids. If we look at Italy, you can see not only are there some regions in Italy that are not covered at all, but where there is coverage, that this varies widely, from 6 in Lombardy down to just 1 in Basilicata. So this is something where we feel that patients need to be made aware of this fact, because we don't want them going to get treatment somewhere and then finding out that their insurance is not valid there. Moving on to the foundation efforts. First of these is our efforts in Europe. The goal there is for us to gain a more complete understanding of the reimbursement landscape in European countries. Outcomes of this is that we've received detailed reports on the reimbursement of focused ultrasound-based procedures, some of these including billing codes and payment rates for Germany, Italy, United Kingdom. In addition, we would love to get a more complete landscape for reimbursement in all European countries. Our other efforts are in awareness and net reimbursement. The goal is to create a greater awareness of the reimbursement process in the US, and to help treatment sites better understand how their payment rates compare to their internal cost of performing the procedures, and to compare these against the standards of care. The outcomes measured against this, in August 2021, Mark Carroll presented the webinar Pathway to Getting Paid for a New Medical Technology in the US. This had 69 live views and 422 online views. In addition, he's created the cost of care calculator. That will be the next presentation. I hope you stay tuned for that. On the advocacy front, our goal is to improve coverage and payment rates for FUS-based procedures in the US. One of the outcomes is that we submitted comment letters offering views on the proposed CMS pathway to reduce the lag time between FDA approval and Medicare coverage. Many people aren't aware of the fact that this gap is currently about 4 years, and it leads to what we call the valley of death for a lot of new companies. We've also submitted comment letters proposing increases in the payment levels for prostate HIFU. This change was made recently by the US Center for Medicare and Medicaid Services in their notice of proposed rulemaking, and we hope this is reflected in their notice of final rulemaking. We've also undertaken robust advocacy efforts with our partners G2G and the Medical Imaging Technology Alliance to build champions in Congress and in the VA to support enhanced coverage of FUS for prostate cancer, uterine fibroids, essential tremor, and Parkinson's disease in veterans. We also have the webinar series, which is the Reimbursement Strategy Program. The goal is to show US-based treatment sites how to better align their internal costs of performing FUS procedures with future Medicare payment rates. Currently, the payment rate does not cover the average internal cost of performing the procedure, so our goal is to improve these payment rates. We're working in close collaboration with Dobson DeVanzo, a health economics and policy firm that's based in Northern Virginia. The outcome of this is that the mean cost values for billing codes in the program have increased 53% since the program began in 2019. And these cost values are what's used in the Medicare cost report to set future payment rates. So we have our fingers crossed that this will lead to some positive changes. So in conclusion, lack of coverage or inadequate payment rates can limit patient access to FUS-based procedures. Global coverage is incomplete but improving, with the number of approved but not covered indications suggesting a strong potential for expansion of this. We also hope that patients will be made aware that coverage in some countries is regional. We've managed to get a better understanding of the global reimbursement ecosystem. Device adoption and understanding of the US reimbursement processes have been improved. Advocacy efforts are underway to improve coverage and payment rates in the US. And Medicare cost values, which are the sole metric for setting future payment rates, have increased for the relevant indications. I'm in the audience today, so if you have any questions or comments, please come see me. Thank you for your time.